All right. Well, I think we are welcoming back, and we have a few new faces with us. Thank you for joining us for the pharmacy presentation. I want to introduce Casey Ogbonna, Dr. Casey, and he is the Associate Dean for Admissions and Student Services for VCU School of Pharmacy. We want to encourage you all to turn your cameras on and to be engaged and ask questions in the chat box. And just a reminder to complete the evaluation at the end that we'll share the link for. Hope to see you at the rest of the sessions today. So thank you, and pass it on to you.
Well, thank you for that warm introduction. Good morning, everyone. Hopefully you can hear me and see my slides. Again, Casey Ogbonna or Dr. O. I'm the Associate Dean here at the School of Pharmacy, and as of tomorrow, I will be serving as the Interim Dean here at the school. And so a lot of transition, a lot of things that are fun and happening here at VCU. But I'm excited to be with you because anytime I get an opportunity to talk about pharmacy, it excites me. And so the first thing I will say to echo what Stacy mentioned is that if you have the ability to turn on your camera, I would appreciate it. I've gotten used to this virtual environment, and so it's always nice when you can talk with folks and see them and put a face with the name. The second thing I will say is that I much rather this be a dialogue than a monologue. So if you have questions, if you want me to elaborate on something, if you want to go off on a tangent, know that I'm more than willing to entertain those questions. And so I'll be monitoring chat, or you can simply unmute yourself and we can have that conversation from there. Does that sound fair? Sound reasonable? Awesome. Okay. So the title of my talk is Healthcare as a Team Sport and How Pharmacy is Changing the Game. I think the traditional outlook on healthcare has always been kind of hierarchical or somewhat tiered in terms of who's the leader on a healthcare team. What does it take to actually take care of a patient? And what we're finding is that patients are getting more and more complex. They have more and more conditions, disease states, medications that they're using. And so because of that, in order to treat them and get the best possible outcomes, we need to have much more of a team-based approach for our patients. And so I'm going to talk a lot about that as we move forward. My background, I am a pharmacist by training. And so I always say I'm a pharmacist first and foremost, and all the other things and titles come after that. And so my purview is as a medication expert. My specialty is geriatrics. And so does anyone know what geriatrics means? What age group? Take a guess, take a stab. Quenisha, can I call on you and just ask you to take a stab at an age group? You're like, no, I don't want to take a stab. Anyone want to take a stab?
Is it like 50 and older?
Not quite 50. It's actually 65 and older, but okay. We're talking about the age of population. That's and Judy put in the chat greater than 65. Maxine said old. I appreciate that answer. So anyone 65 and older. And so this is always kind of an oddity for folks when they think about specialty areas, because you might think about transplant pharmacy or emergency room pharmacy or veterinary pharmacy. Well, geriatrics is all its class of its own, because just like in a pediatric patient or a little child or baby or a kid, we have to be careful about how we administer medications. There are changes in our bodies as we age that impact the way in which we digest, metabolize medications that can have very different consequences and side effects if we're not careful. And so that's my specialty area. So long story short, from Philadelphia, grew up in New Jersey, went to an undergrad institution called Fairleigh Dickinson University. It's in northern New Jersey. I was playing football. I was about 260 pounds. I was waiting for the NFL to give me a call. I'm still waiting. They haven't called me. And so I realized I had to do something with my science background. And so I went to pharmacy school in Massachusetts. And up until that point, I had worked for the big three: Walgreens, Rite Aid, CVS. I loved everything about community pharmacy in that most folks go and see a provider, they get a prescription, and they have no idea how it works. They have no idea if it interacts with their other medications. And so I was the one that was able to fill in the gaps to say, you should avoid taking it with this, or these are the side effects you might expect. And so that was a really unique outlet and an opportunity for me as a community pharmacist or a student studying to go into pharmacy. And then I got to pharmacy school, and I had no idea as a pharmacist you could work for the FDA or you could work for a drug company like Pfizer and work on vaccine development for COVID-19, or that you could work at a zoo as a veterinary pharmacist, or you could be a transplant pharmacist. And so it opened my eyes into what was really available and the things that I could actually do with my PharmD degree. After pharmacy school, I decided to do a residency. So just like in medicine, where you can go on and specialize, you can also do that in pharmacy. And so every specialty that's available across medicine is also available across pharmacy. And so out of due diligence, I went to the VA healthcare system in Connecticut, so serving vets, spent 2 years there to specialize in geriatrics, spending time at the VA as well as Yale Hospital. It's one of the few hospitals in the country that has an ACE unit or acute care for the elderly. And so that's my background and training prior to coming to VCU. So the purpose of this conversation today is to talk specifically about all things pharmacy and healthcare and how things are changing. And so this is my roadmap of what I hope to cover in the next 30 minutes or so. We'll talk about why pharmacy. I'll kind of give you some perspective of what it looks like to be a pharmacy student in a school of pharmacy. And then I'll open it up to all of you. We can talk about pharmacy school and what it takes. We can talk about the opioid epidemic. We can talk about COVID-19 and vaccines, really anything that's top of mind for all of you as it relates to pharmacy and medications, I'm open to. So to that end, it's important that I ask you what comes to mind when you think about pharmacy or pharmacist. So feel free to add it to the chat or unmute yourself. Medications, prescriptions, awesome. Does anyone venture to guess? Taking care of people, that's a really good, good synopsis. Anyone know where pharmacists actually practice? So where will you find a pharmacist? Kayla said healing, pain relief, vaccines and medications. Excellent. Where do pharmacists actually practice? Where can you find a pharmacist? Yep, CVS in a lab. Yep, absolutely. They're a research pharmacist. You may be surprised to find out that I'm sitting right across from VCU Health System. It's a level 1 trauma center. There's about 900 beds here at VCU Health, and there are about 110 pharmacists that work just for this one facility. 110 pharmacists that work for this one facility. And so their roles vary. So the hospital free clinics are opportunities or areas that you find pharmacists. Here at VCU Health, you'll find that there's a pharmacist almost in every specialty: infectious disease, transplant, cardiology, critical care, emergency room. You also find that there's pharmacists in the pharmacy helping ensure patients are getting the best care possible. And so a lot of times folks think, well, if you get admitted to the hospital or you go to the emergency room, your physician might write an order and say, okay, this person needs a blood pressure medication. And so they put it in and think it goes directly to the patient. What actually happens is it goes to the pharmacist, and the pharmacist verifies that that medication is appropriate for the patient that it's been prescribed for, to make sure there's no drug interactions, to make sure their kidney function, their liver function can actually handle the medication that we're providing. And so there are a lot of pharmacists in a number of different settings. And so we'll talk about where you will find them as you think about your community and the healthcare environment around you. So I'm going to start with this diagram. There's a lot here, and I'll kind of walk you through it, but this is the changing landscape in healthcare. So the first thing that you will see is the ACA. That's an abbreviation for the Affordable Care Act, sometimes called Obamacare. Whether you love it, whether you hate it, whether it stays, whether it goes, it's changed the way in which we approach healthcare for a couple of reasons. And the technical term that I won't use throughout the presentation is going from a fee-for-service model to value-based care. What does that actually mean? So let's say you get sick. What's the first thing that you're going to do if you are really sick? What do? Call 911. Excellent. So you call 911. Maybe you take an ambulance to the emergency room. And if you get better or you get worse, it actually doesn't matter from a payment perspective. That healthcare system, that provider still will get paid, whether it's through you or your insurance, whether you get better or whether you get worse. It's kind of strange to think about healthcare in those terms. Think about if you had a car that breaks down and you took it to the mechanic and you dropped it off and said, there's something wrong with my car. I need you to fix it. And they say, come back in 3 hours and we'll take a look. You come back in 3 hours. They say, hey, we couldn't fix your car, but it's still going to be $5,000. Most of you wouldn't pay that money if they didn't fix your car. But unfortunately, healthcare works in a way where whether you get better, you get worse, there's a charge, there's a reimbursement. Well, the Affordable Care Act has forced us to think about value-based care. So I have a diabetic patient that has blood sugar levels that are out of control, and I'm a provider taking care of them. In most settings, my reimbursement, the amount I get paid, is now going to be based on whether or not I get that patient to optimal outcomes. And so this is part of that team-based sport piece, because now providers, clinics, hospitals are thinking critically about who needs to be on the team to provide that diabetic patient the best possible care. And so if I'm dealing with diabetes, I might need the nutritionist or dietitian. I definitely need the pharmacist, the nurse, the physician. And so we're all looking at the patient and looking from our vantage point or lens to provide the best possible outcomes for that patient, and in turn, the best possible reimbursement or payment for those services that are rendered. And so that's a major change that we're seeing in healthcare. The other thing is this idea of increasing comorbidities in the setting of increasing longevity. That's just a fancy way to say we are all getting older. I don't know if anyone on this call has thought about how long they want to live. I know it's kind of a morbid discussion, but does anyone have an age in mind where you feel like, if I live to this age, I'm happy, everything's good, and that's all I need to do? Anyone have an age in mind? You can 82. Kayla says 82. Okay. Kayla, can I ask you what's special about 82? Quenisha says 90 some, so 90 or older and you're good at that point. Well, there's this concept called successful aging. That's just long enough for me. I get it. I like it. Successful aging is the idea that you live as long as you can, still able to do the things that bring you the most joy or are most fulfilling. What we know as a healthcare system, particularly here in the United States, we are woefully underprepared to care for our older adult population. And so as folks reach 65 and older, longevity, life expectancy has never been higher than it is now. But what I can guarantee you, and so as I look at the two responses of 82 and 90, I can guarantee you if you lived 82, 90, maybe even 100, 102, 105, you will have a lot of disease states that come with that age. And so we've done a really good job at prolonging life. We haven't done a great job at avoiding disease. And so because of that, as a society, we become more and more medication dependent as we move along. And so there is no better population for a pharmacist to actually intervene, serve, and assist and help than the older adult population, because as we age, we add more and more medications to treat the disease states that are ailing us over time. The last important change in healthcare that we'll talk about today is this idea of personalized medicine. That's the idea of making medications that are specific to the individual. Traditionally, big pharmaceutical companies have made aspirin, Tylenol, Motrin, ibuprofen, and they said, if it's good enough for you, then it's good enough for me. What we do know is that our DNA is different. It changes. And so it changes from one person to another. And so the medication that works well for me may not work well for you. And so there's a large movement to look at personalized medications and thinking critically about pharmacogenetics and thinking about your DNA and how we can cater or tailor medications that are unique to the individual or person. So for example, we're seeing this a lot in mental health with antidepressants. Generally in a clinic setting, it takes me 3 to 4 medications to get to the right antidepressant for a patient. Because one, it may not be all that efficacious or work that well for the individual, or there may be a lot of side effects. And so we have to switch quite a bit to get to the right medication. That switching takes 3 to 4 weeks before we get the full effect of each medication. So we could be 3 to 4 months down the line before we actually get to the right medication for that patient. Well, if I know your DNA, I know how you metabolize medications, and I know some of the side effects that you've previously been exhibited, I can pick the right antidepressant for you right from day one. And so that's the idea of using your DNA data to drive medication therapy. Other things that are really cool that are happening, 3D printing. The FDA about 5 to 6 years ago approved the first 3D printed medication. Some of you may say, well, why is that innovative or fascinating? Well, right now it takes a lot of money to actually make medications. It also takes a lot of money to transport medications, store medications. And so if we think about areas that don't have a lot of means, imagine if we could go into an HIV clinic and print medications for that population right on site as they need it, rather than all the costs associated with making it in mass, storing it, transporting it, and everything in between. We also have a project here at VCU where we are thinking about how to make poly pills. Geriatric patients can sometimes take 13 or 14 medications on a given day. What if I can give them one tablet that has all 13 or 14 medications built into that tablet that's slowly released over time, that avoids drug interactions and provides consistent levels of medication over the course of a day? Those are the types of things that are now available to us, particularly as it relates to 3D printing and having the ability to make those poly pills. So some really cool things that are happening in that way. Questions about any of that? Questions about the landscape, things that you want me to talk more about, things you're curious about? Where's the science with poly pills? There's actually a lot of literature related to poly pills. So if you look up poly pills or poly manufacturing, the idea is that if a patient is on a stable regimen, let's say they have diabetes and high blood pressure, and they take the same medications day in and day out, there are certain medications that we can actually combine or put together in a pill, maybe with layers, that are slowly released over time. And so there are special coatings that we can apply to the different layers to make sure that one gets dissolved before the other. There are certain things that we can consider related to drug-drug interactions. And so there's an idea that rather than having to take 3 or 4 medications throughout the day, you take your one pill in the morning and you've taken all your medications that you need to for that given day. And so there's a lot of new evidence that is pretty cool in that regard. So more to come, but there are already poly pills that have been developed, and we're trying to get more complex with those poly pills as time wears on. Great question. Thank you, Judy. Other things that are of note or interesting, particularly in this COVID pandemic environment. Many of you have been vaccinated. Some of you have gotten a booster. Some of you have gotten 2 boosters. Some of you are thinking about 3 boosters. We have a pharmaceutical scientist that's here that's actually thinking about vaccines and patches. Imagine if you didn't have to go back for that 2nd or 3rd dose. You could wear a patch for, let's say, 10 to 21 days, and it provided you the inoculation that you need. So thinking critically about medications is important for pharmacists and pharmaceutical scientists, but also thinking about how we administer them. Are there better ways to get the drug into the body, and does it save us the ability to have to continue to come back for additional administrations? And so those are some really cool things that are cutting edge, that are happening in healthcare, that are really in that pharmacy medication space. So I've given you a lot of information to digest in a little bit of time. And so if I've even piqued your interest, I think the next thing I should do is give you a broader understanding of, if you've seen one pharmacist, you've seen one pharmacist. Most of you have interacted with a community pharmacist, and we have fantastic community pharmacists that are on the ground and really are your most accessible healthcare provider. If you think about any health profession, you can always find a pharmacist, no matter what city, what town that you actually go to, and they're incredibly well trained. However, most folks don't get to interact with the variety of pharmacists that are truly in the healthcare space. So what do I mean by that? So community pharmacists, we've just described. Think about CVS, Walgreens, Rite Aid, Walmart. But there are a number of pharmacists and a number of my students that are also entrepreneurial, that start their own independent pharmacies. And so you can find folks like that. There are a number of folks that are doing compounding pharmacy. So not every medication is readily available. Sometimes, like me, I have a young child that doesn't want to take pills. Well, can I get them to compound a medication in a suppository or a lozenge or a lollipop? There are pharmacists that do home infusion. And so if you think about a patient that has an infection and it goes to their bone, that's one of the most serious types of infection a patient can have. We call it osteomyelitis. Well, generally that infection needs 6 to 8 weeks of antibiotics via IV. We don't keep patients in the hospital for that long. Instead, we send them home and get them set up with a home infusion pharmacist to administer those antibiotics over time. Those 3 domains are just 3 types of community pharmacists that I've just described. looking here, Kayla, it's okay to go off topic. I want you to ask questions. So do you consider polypharmacy a growing issue with younger generations than older, especially with kids having better technology, like pills being brought offline or from so many doctors? Polypharmacy is a growing concern across populations. It's most common in geriatrics. So most folks think about pharmacists as encouraging folks to take medications. My role as a geriatric pharmacist is generally encouraging folks to pull back medications and trying to avoid what we call the prescribing cascade. That means when we add a medication and it causes a side effect and we don't recognize it as a side effect, so we treat it with another medication and the cascade continues. And so polypharmacy is a major concern in the geriatric population, but also in a society where we become very dependent on medications itself, it can be a concern for other populations as well. And so I think what's important is one, education, two, finding your pharmacist that's really knowledgeable about these pieces and realizing anything that is foreign to the body you put into your body can be considered medication. So even things that are over the counter count as medications, even if you don't need a prescription for them. And so being mindful of those pieces moving forward is going to be incredibly important. So Kayla, hopefully that answered your question, and feel free to pose others along the way. So other types of pharmacists, nuclear pharmacists, these are folks that work mostly with radioisotopes in oncology, so think cancer. In cancer, we are generally giving toxic chemicals to our patients. And our hope is that these chemicals, this chemotherapy, is more toxic to the cancer than it is to the host. But in order to do that, you need a specialized type of pharmacist to manage those medications in a really meaningful way. You have academic pharmacists that teach. You have public health pharmacists. So think Doctors Without Borders, but the pharmacist edition. I have a number of students that graduate every year and go work for the public health service as a pharmacist. We have inspectors. These are folks that work for organizations like the FDA or the DEA. We have consultant pharmacists. These are folks that work at nursing homes or assisted living facilities, making sure patients get optimal care as it relates to their medication therapy. And then you have a huge category of clinical pharmacists. These are many of the folks that are specialized in all of the areas of medicine that I've talked about before, from the cardiology and critical care to pediatrics and everything in between. And most of these folks are embedded on a healthcare team and they're a medication expert. So the physician might say, you know, we've identified E. coli in their blood and we need to treat it. They're going to look to the pharmacist and say, what antibiotic do we use that's safe for this patient, but also has susceptibilities in our community, meaning that if we give it to the patient, it'll actually work for the infection that they do have. And so there are pharmacists that are embedded in all these clinical areas to be able to provide that expertise. Does that make sense? Are there questions so far about the different types of pharmacists that are out there? Okay. So here are two of my good friends, and we put them on billboards and bus stops across Richmond. On the left, you see Tammy Nguyen. Tammy is our ED pharmacist here at VCU Health. She did her pharmacy training, not here at VCU, but in Chicago, did her residency training at UIC, and she's the emergency room pharmacist here at VCU. And so if you come in an emergent circumstance, she may be the one that's providing compressions. She's likely the one that's drawing up life-saving medications to be administered. If a patient comes in with a drug overdose, she's usually the one that's thinking critically about naloxone or other types of agents. And so her role in the ED in that acute setting, in that critical moment, is determining the medications that patient might need in order to survive the next few hours or the next few days. Dr. Idris Yakubu is a good friend as well. He's our transplant pharmacist here at VCU. Idris, his role is to think critically about how do we transplant patients with new organs. And so if it's kidney transplant, if it's a heart transplant, his role is to administer and think critically about the cocktail of medications that are needed to make sure the patient's immune system does not reject that new organ. So oftentimes, there's some type of tragic circumstance where a patient is no longer with us, but their organs can be harvested and provided to a new patient, give someone a new lease on life. So that organ will be helicoptered in here to VCU, and we are thinking critically about the patient's needs and the anti-rejection medications that are needed, not just in the short term, but the long term, to make sure that we have the best success possible with that new organ that's been transplanted. So again, just two examples of two pharmacists that are specialized in a healthcare setting, perhaps where you hadn't considered or thought about a pharmacist before. So I do need a little bit of participation, particularly for the next few slides. So can anyone tell me what you see on your screen right now? An asthma thing. I love it. An inhaler. Excellent. An inhaler. Awesome. And it's okay. I'd rather you participate than know the name. And it lets me know that you're paying attention. So in most of our rescue inhalers, does anyone know the main medication or main drug that we use in our rescue inhalers in this asthma thing? Albuterol. Awesome. Okay. Judy, Jenny, thank you. Albuterol. Does anyone know how albuterol works and why we give it for asthma or COPD? Oh, look at that. Expands alveoli. Bronchodilation. Awesome. Okay. So excellent. So albuterol we actually use to help bind in the lungs to actually cause some vasodilation, to get some actual bronchodilation and allow increased airflow. So patients that have asthma or exercise-induced asthma or chronic obstructive pulmonary disease, rescue inhalers can be incredibly effective in the moment to allow increased airflow, to allow that person to breathe. One of the things that you'll learn in pharmacy school is how medications interact in the body and how they can provide great benefit and how they can also cause great harm. So the mechanism of action for albuterol is specific to the beta receptors. And so this is a pretty cool pharmacology lecture in 5 minutes or less. Albuterol binds preferentially in the lung. So we have our beta-2 receptors. Albuterol will bind to those beta-2 receptors, cause that bronchodilation, and allow the person to breathe. However, when overused, and when there's a lot of albuterol in the system, we'll get binding in our beta-2, but also we'll get binding in our beta-1 in our heart. If albuterol starts to bind at beta-1 in the heart, what do you think might happen? What types of side effects or symptoms might a patient present with? Tachycardia. So excellent. So tachycardia, so fast heart rate, jitters, anxiousness, sometimes shakes. Patients will feel overly anxious at times. And so this is always a telltale sign. And as a pharmacist, particularly a patient coming in and saying, you know, I can breathe great. However, and yes, in hyperactivity in kids, it can actually be kind of bouncing off the walls. I can always tell when a patient may be overusing the albuterol. And so it's an opportunity for counseling, but it's also an opportunity to readdress their therapy. And this is where the healthcare as a team sport comes in to say, okay, do we need to get with your providers and think critically about other maintenance medications or other things we might need to do in order to better control your breathing concerns. And so in pharmacy school, you're going to learn all about the medications for certain disease states or conditions and how they act in the body for good, but also what can go wrong so that you can identify those pieces along the way. The second thing you're going to learn about is formulation and delivery. So how do we get the medication to where we need it most? And so albuterol, for example, is great for, you know, someone like myself that I can time the actuation or breathe in the mist at the right time. But what about someone that's, you know, 2 years old or 1 year old? Well, we also have albuterol that comes nebulized in a gas form where we can give them a mask. And so part of the role of pharmacists is not only determining the best medication at what dose, but also thinking critically about the best formulation for the patient that's in front of you. And then dose identification and symptom monitoring. So really helping the team understand what dose is going to be most effective, when to reassess, and how do we know if the patient's actually getting benefit or getting harm for the medication that's been prescribed. So all of these things are going to be vital, crucial components to thinking critically about pharmacy, but also thinking about, if I want to be a pharmacist, what do I learn about? What do I do as a pharmacist, and where can I actually practice? And so hopefully this closes the loop on those pieces with one example to say, you're going to learn about this as it relates to cardiology, dermatology, neurology, And the list goes on in terms of all the areas in which you'll be the medication expert and truly understand how the medications work to provide benefit. So this is not an exhaustive list, but a lot of ways in which pharmacists kind of apply their skill set. So compounding, gathering information about patients, counseling on possible side effects, monitoring drug interactions, advising for treatment. And even in some circumstances, most folks don't realize that pharmacists actually can prescribe. So when I was at the VA, I actually had prescriptive authority as a pharmacist. I had my own panel of patients. I was one that was managing their anticoagulation or their diabetes medication or their high blood pressure medication, and making those changes or starting them on therapy or stopping them in therapy and seeing them back. And so in a lot of settings, there are pharmacists that are prescribing as well. And so it's another aspect or another variation of where you find pharmacists and the type of work they're doing in those clinical settings. So I should pause and ask, are there questions at this point or things that you want me to elaborate on further? Okay, not seeing anyone unmuting or anything in the chat. So I want to tell you a little bit more about the path. So let's say you say to me, Dr. O, this sounds intriguing. I want to know what I need to do in order to be a pharmacist. What is that career path and education path? What does that actually look like? Well, there are two routes from high school. One is a 0 to 6 route, and one is more of a traditional route. So there are a few 0 to 6 programs that are out there where right out of high school, you can say, I want to be a pharmacist, and you enter a 0 to 6 program, meaning that you're going to be in school for 6 years and you finish up with your Doctor of Pharmacy degree. So basically, almost in a sense, skip over the bachelor step, spend 6 years and get your doctor in pharmacy. There are other programs such as VCU where you get your prerequisites first. So you will go to undergraduate institution, whether that's community college or 4-year degree granting institution, and either do your bachelor's degree or finish your prerequisites and then apply for pharmacy school. And our program is 4 years. And so that can be anywhere total 6 to 8 years to get your doctorate in pharmacy degree. And so it depends on whether or not you really want the college experience as an undergrad, whether or not you're really sure about your path right now, or if you want to get that bachelor's degree first or have some additional experiences prior to committing to the Doctor of Pharmacy program. Regardless of your choice, in our program, you'll spend 4 years here. And then, unlike medicine, when you are done pharmacy school, you can go out and work immediately. You can go directly into practice. Whereas in medical school, after you're done medical school, you have to do a residency. You have to do additional training. And so in pharmacy school, you get all the skills and tools that you need in order to go out and get licensed right away. So some of you may go to pharmacy school, get out, get licensed, and go work immediately. Some of you will decide to do a residency and get additional training and maybe even specialize in a certain area. Some of you instead will decide to do a fellowship because you want to be more research oriented. Maybe you do want to work for a Pfizer or a Forest or Eli Lilly, for example. Regardless of your path, there are a number of things that you can take on, a number of things that you can experience with that training and that expertise. And so I've talked a little bit about the residency fellowship route. If you go the hospital route, you'll be in a hospital pharmacy. It may be nuclear or some type of specialization or rounding with the team in a certain setting or area. If you go the education route, you might be at a university teaching, for example, or you might be doing medical communication. So there's a number of pharmacists that work as medical writers, if you will, trying to provide information to individuals that are not really all that familiar with healthcare to help them understand their therapy, their treatment, or a medication, for example. Community, we talked about the pharmacy chains, independence, but there's also veterinary pharmacy. I have a student that graduated a few years ago that did her residency at NC State, and part of her role during residency was actually taking care of the wolf pack that lived on campus. And so she worked at a zoo, she worked for Sam's Club, she worked for Petco as examples of how she could apply her skill set, particularly as it relates to animals. And then we talked about compounding and free clinics and the alike. The consulting, I talked about long-term care and home health, drug development, thinking about industry and working for a pharmaceutical company. And then there's this other category where anywhere there are medications or medication decisions to be made, you'll find a pharmacist. That may be, the prison system, that may be the managed care setting. There are a lot of opportunities and things that you might consider along the way. So that's a perfect segue in terms of questions about overall cost. So what does it cost to go to pharmacy school? What are the things that I need to consider? What's the return on investment? So I've already answered this for you, how long it takes. It's anywhere from 68 years total that you'll be considering for pharmacy school. Most PharmD programs have tuition somewhere in the range of $25,000 to $45,000 annually. That's every year. So it is a significant cost that you'll have to consider. Know that there are a lot of scholarship opportunities and creative ways in which you can pay for pharmacy school. Scholarship opportunities, I can speak from experience at VCU. You can apply for merit scholarships or need-based scholarships. There are a lot of companies and organizations that will actually pay for your pharmacy school if you're willing to provide service afterwards. So what I mean by that, let's say you want to be a commissioned officer in the Navy, the Air Force, or you want to work for a company like CVS. If you are willing to say, I'm going to work for you for 3 years after I graduate, they may be willing to pay 2 to 3 years of your actual pharmacy education. Other things that I think are important as it relates to thinking critically about that return on investment is the average salary. No one's going to go into healthcare because of the money, but it is important to know if it's good a return on investment. And so does anyone know what the average salary for a pharmacist coming right out of school is right now? I see 150, I see 73, quite a range there. So right now, the average is right about $126,000 to $127,000 coming right out of school with no additional training. And so I say that to you to say that it is a really strong return on investment right out of school. And so again, it's not going to be about the money, but it's important to know, what are you walking into after your PharmD degree? So I want to address some of the questions that came through. One, we talked a little bit about the scholarship piece and internships. And so many of my students that are enrolled from day one, they actually get intern status with the Board of Virginia, the Pharmacy Board of Virginia. And so they can work in hospitals and community pharmacies and pay some of their way through school. And we help facilitate that. Other things that may come up in terms of the pharmacy path is, what do I need to do, or how can I be a really strong candidate? The memory piece and all the medications, it's really hard to keep up. There's a new medication that comes out weekly. And so the idea is that you're not memorizing every medication that's out there. The idea is that you understand the basics or a foundation for different classes of medication, so that when a new one comes out, you have a general understanding of how they've improved it or how it may work based on its classification. And so a lot of what we teach in pharmacy school is about classification and what we call structural activity relationships, so that when a new drug comes to market, based on its name, based on its classification, you have a general sense of how it works, and then you just need to read up on what makes this one a little bit different. And so strong memory is helpful, but know that you're not going to be expected to memorize every medication that is out there, because you just simply could not keep up. But part of being a pharmacist is also the continuing education. And so in order to keep your license current, you will have to do some continuing education annually to keep your license. Kayla, you had a question of, how do you feel confident enough to know the etiology and reactions for so many medications? Do you think it's okay to not to know a med? And do you own research for a medication? So again, you don't have to memorize everything about a medication. What's important is that you have a general understanding of what types of medications treat what. And so sometimes I have to look things up, and that's completely okay. Patients rather you look up information to be able to educate them or provide the best possible care than simply trying to go off of your rote memory. And so I think that's important. Judy said, I'm on my way to completing my doctorate degree in nurse in DNP. I will be graduating in December and hoping to practice a primary care provider. Are there pathways to get an additional degree in pharmacy science? Passionate about helping geriatric patients to reach polypharmacy as safely as possible. That is a great question, and Judy, congratulations to you, by the way. A lot of my good colleagues are NPs. There is not an additional degree specifically related to pharmacy. However, there are a number of certificate programs. One great resource I can tell you is the HDS, American Geriatric Society, for example. They have a number of certifications that relate to pharmacy and certification courses that one can take related to polypharmacy or prescribing cascade. And so that might be where you start to get that additional information. All right, what else? Thank you, Stacey. That was quick. Appreciate that. All right, so what I want to do is I want to show you a quick video that will truly detail what it's like to be a pharmacy student. So those of you that this has piqued your interest, what do you actually learn? What does that look like? I've talked for quite some time, but I think it's sometimes much better to give you a live demonstration of what that might look like. So bear with me. All right, so hopefully you all can see this video. Can I get a thumbs up? Excellent, perfect. All right, I'm going to play the video, and I want you to pay particularly close attention to what our students are doing day in and day out, from lab activities to taking blood pressure to doing glucose, to doing simulation. And so hopefully this gives you some pretty good perspective. So that is pharmacy school in a nutshell, in 3 minutes or less. Hopefully it gave you some perspective on the types of things that reinforce what I talked about in terms of what our students are doing and why they are serving in the role they are in the healthcare setting. What I want to do with the time that we have left is really answer any questions that you might have. Are there things top of mind, things that I didn't touch on that you were hoping I would touch on? This is your opportunity. Oh, and I'll definitely answer that question about the COVID piece. So let me start. Yeah, go ahead.
I was just going to say, feel free to unmute and ask questions and engage with him. This has been very enlightening. I've really enjoyed your presentation. Thank you.
Thank you. So let me start with the COVID piece while folks think about their questions. So like many of you, COVID threw things for quite a loop in terms of having to move back to mostly a virtual setting and to think critically about the healthcare need as well as the educational need. And so our students were actually on the front lines of the COVID response as it relates to vaccination, because we were one of the few professions that had vaccination training early in the curriculum. And so our first year students were actually deployed across the Commonwealth to help with vaccinations once they were available. So that was kind of helping meet the healthcare need. What you will find is that if you're interested in healthcare, you're considered a mandated reporter or sorts, or essential personnel. And so our students need to really embrace the idea that in a public health crisis, they're going to be called upon just as if they were in the profession to help meet the needs of their community. And so that was a really important lesson, but also incredibly valuable one for them. And so we still had students that were on rotation in healthcare sites, helping provide patient care and respond to COVID. The didactic component, or the actual classroom components, is what changed the most. So for most of our in-person classes, we actually did move to a virtual circumstance, but you can't teach compounding virtually. How can you manipulate and get hands-on and make chapstick and make tablets? And so what we had to do is set up COVID-friendly small cohorts to actually come to campus in designated time slots. And so we had small lab groups. Those students were required to double mask. We had separation and physical distancing in all of our lab spaces. And that's how they actually worked through much of their simulations and compounding experiences. And so it took much more time to be able to do that and get every student through that experience. But every year they had a different activity that we either front loaded or back loaded, depending on where we were in the pandemic, to make sure they still gain that skill set throughout the pandemic. What is a challenging barrier pharmacists go through? I think one of the biggest barriers, if you were to Google search pharmacist and pharmacy profession right now, you might actually see a lot of negativity. One, I think across healthcare, there's a lot of burnout as it relates to COVID. And so there's some concern about our healthcare workforce, not just pharmacy, but across the board, in terms of how long have they endured being the front-facing piece of this public health crisis. Secondly, I think there is not great awareness of what pharmacists actually do beyond the community setting. And so many of you coming in this conversation probably were very well familiar with the community pharmacist, but had no idea of all the specialty areas that I mentioned and the amount of pharmacists that are working in the health system side. And so I think one of the biggest barriers, honestly, for the profession is that awareness piece. And so every time I meet with students or talk with folks that are changing careers, I'm often helping them understand the rich nature of the profession and how you can actually reinvent yourself multiple times over. My wife's a pharmacist. She works here at VCU Health. She's an anticoagulation pharmacist. Some of you may not know what that is, but if you come in with a stroke or a clotting disorder or some genetic predisposition and your blood clots up, she's the one that prescribes the medication to make sure that you don't have clots anymore. And she does that, and she works pretty much 9 to 5. My father-in-law is a pharmacist. He's what we call a remote entry pharmacist. He's actually licensed in about 23 different states. He works for HCA, and he actually verifies prescriptions from home for hospitals that are across the country. And so the idea being that there are some hospitals that don't have robust pharmacy services. And so when a physician or a PA or a nurse practitioner puts in an order, there still needs to be a check to make sure it's appropriate. And so he's the one that provides that check off-site virtually for those health systems that don't have those robust services. So there's so much to pharmacy that most folks don't see. And so I think that's one of the largest barriers of helping folks understand, to say, there's a lot you can do with a PharmD degree, and you can actually reinvent yourself multiple times over. Yes, and then social determinants of health is incredibly important. What I didn't tell all of you is the reason I came to Virginia was because I had an amazing opportunity to come and build out a clinic that was interprofessional. And so in most settings, when patients are sick, you ask them to come to the healthcare system. In my circumstance, I wanted to provide healthcare where it was needed most. And so we actually went into Section 8 and tax credit buildings and set up a clinic a half day a week in various buildings across Richmond. And we had pharmacy services, medical, nursing, social work, and we provided care as a team to the patients that lived there. And the idea was, as a healthcare provider, doesn't matter if you're a pharmacist, physician, nurse, if you prescribe or give a patient a medication and expect them to get better, you're going astray. You're going down a incredibly treacherous path, because you haven't considered, does the patient have somewhere to live? Do they have the means or the funds to actually pick up that prescription? Do they have transportation to be able to get to the pharmacy, for example? And so social determinants of health, thinking critically about all the pieces and parts that lead to good patient outcomes, is incredibly important from a provider's perspective. And so it's something that I consistently think about when we're prescribing or when we're thinking about therapy for a patient, to say, this therapy is great. And we know based on our education that it treats this condition. But if I don't consider all the patient-specific factors in actually providing that medication, I'm failing the patient. And so those social determinants of health is incredibly important. And we got some grant funding, a little over $1 million to refine and replicate that model. And so the clinic still lives to this day in about 6 Section 8 tax credit buildings across Richmond. And so if you're interested in more information, it's called the Richmond Health and Wellness Program or the Health Hub at 25th. Those are all examples of that type of approach where you bring healthcare to the community and you bring a professional team of folks or multiple healthcare providers as a team to treat those patients. What else?
Those hubs are so important for the community. That's a wonderful thing that brought you here. And it sounds like your whole family is doing such interesting things in pharmacy. Just so enlightening. You know, you don't even think about all of these realms in that profession.
Yeah, for sure. So there are a couple of pieces that I would be remiss not to describe. So the QR code on the left, if you're interested in just getting more information about pharmacy, you can feel free to subscribe here. We send out a newsletter. It's usually every month or quarterly. The QR code on the right is probably the most important for up and coming students. And the reason I share this with you is as you think about the financing and thinking critically about, you know, can I really afford to go to pharmacy school, or can I really set myself up for success, or, you know, I'm not sure I'm a strong student. This QR code will take you to our pipeline program page. There are things for middle school students, high school students, college students, all of them with the lens of providing the preparation and exposure to help us meet the needs of our healthcare system. And so this is not pharmacy specific. I'm a believer that we do need healthcare as a team-based sport. And so you'll find that there are a number of professions that have programming built around the idea of how do we coach up the next generation of practitioners to be able to meet kind of the challenges that we face as a society. So if that's helpful, feel free to take a picture of that. But I think that's a good starting point for many of you that are still considering what you want to do in healthcare and how you can prepare yourself along the way.
All right, thank you so much for that presentation. There's still a few moments if you have any other questions to drop in the chat. You can do that now. All right, and I'm also going to go ahead and drop in the chat, of course, the evaluation link. Of course, we are putting that on each presentation. Complete it once. That's all we're asking at the end of the day. You can put that in there. Up next is going to be lunch. That's going to be from 12:15 to 12:45. So I hope you're grabbing your sandwich and your soda and you get to sit back for a little bit and relax. Our next presentation will begin at 12:45, and that's going to be imaging. And I'll also put that link in the chat. All right. And with that said, we thank you so much for your presentation on pharmacy. I did not know that it was just so detailed. I'm learning a lot, as well as all of these participants, and appreciate all the work that you're doing in your area. So thank you very much for your time today and sharing that with us.
I very much appreciate it. It's been an absolute pleasure. If I can help anyone moving forward, please don't hesitate to reach out, and thanks for the opportunity.
All right. Thank you so much. All right, everyone. Those
we
links,
appreciate it.